Good afternoon, everyone. So these are the cases which we did in our hospital with the help of a multidisciplinary team. So this mother is a woman with mother with complete heart block. So what is the unique of complete heart block? So normally in pregnancy, as pregnancy progresses, the heart rate increases. But in a woman with complete heart block, heart rate will be constant. So it will not increase. And that too in a twin pregnancy, the demand will be more, where the chance of mother getting complications like syncope, sudden death, stroke Adams attack, complications will be more. This is our case, which we could successfully manage with the help of the cardiologist and anesthetist. So, what is complete heart block? It is a third degree AV block characterized by complete atrioventricular dissociation, where atrial impulses fail to conduct to the ventricles. Most common in pregnancy is congenital rather than acquired, and the incidence is 1 in 15,000 to 20,000 pregnancies. So, as I told, twin gestation, there will be increased maternal cardiac demand, leading to challenge in the management of pregnancy. So, this lady at 26 years of age, second gravida, DCDA twin, she had a congenital heart block diagnosed at the age of 20 years when she had a sudden syncope. And she doesn't have any other connective tissue disorders, rheumatic heart disease, or any symptoms. So she is an asymptomatic lady, now became pregnant, and that too spontaneous conception, DCDA twins. And her baseline heart rate when she was referred to me at 33 weeks was 40 to 45 beats per minute. And before coming to me, her antenatal course was asymptomatic and she doesn't had any cardiac symptoms. And when she came, we did a walk test, exercise test, and her heart rate didn't increase beyond 50, but she doesn't had any complaint. And at 36 weeks, she was admitted with labor pains. And on examination, at the time of admission, her heart rate was 46 beats per minute, and DCDA twins, normal growth, and ECG of the lady. So, after seeing this ECG, gynecologist, we should suspect normal or abnormal. That we should do first. So, this is not a normal ECG because all P waves are not accompanied by QRS complexes. So, there is no association between P waves and QRS complex. So, in a complete heart block, the P to P interval and R to R interval will be maintained, but there will be more P waves than QRS complexes and no association between P wave and QRS wave. So, as she came with labor pains and twin gestation, we planned a multidisciplinary team care first done. Cardiologist saw her and we thought we will insert temporary pacemaker prophylactically, and if she deteriorates or heart rate comes down, we will switch on the temporary pacemaker. So, temporary pacemaker was inserted and we did a cesarean section, and both the twins were fine, and post delivery her heart rate dropped to 36. So we activated the pacemaker, and after 24 hours, as the patient was stable, we weaned off the temporary pacemaker, and she was discharged on a stable condition on post-op day 4, and she is under our cardiologist follow-up. Sir, anything you want to add on temporary pacemaker, sir? Okay, temporary pacemaker, this is the X-ray after delivery, and we put in the antenatal period under ultrasound guidance because not to expose the fetus for radiation. Post-delivery, we took an X-ray and we could see the temporary pacemaker, and the lead was in the right ventricular apex. And so we have two types of escape rhythms. Normal sinus rhythm, junctional escape, ventricular escape. How to differentiate whether it is a junctional or ventricular? In junctional escape rhythm, there will be narrow QRS complexes, and ventricular escape rhythm, there will be broad QRS complexes. So I told normally heart rate increases in pregnancy, but in complete heart block, the heart rate is fixed between 30 to 50. So chances of complications and fetal growth restriction, preterm delivery, and mother having syncope, arrhythmias will be more. So what are the management principles in a woman with complete heart block? We need to do ECG, echo, check for symptoms, and see for the fetal growth. And we should avoid AV nodal blockers like digoxin, beta blockers, calcium channel blockers. And permanent pacemaker is advised when heart rate is less than 40, wide QRS complex like ventricular escape rhythms, and temporary pacemaker only if the woman is unstable either in the intrapartum or postpartum period, and vaginal delivery if the patient is stable, and we need to monitor for 48 hours. So in our case, though the woman is asymptomatic with narrow QRS complex, as the heart rate is less than 50, we went for prophylactic pacing. If the heart rate was more than 50, no need of any prophylactic pacing as per the European Society of Cardiology 2025 guidelines. So coming to contraception, as we know, OC pills are better to be avoided and safe for barrier and copper IUDs. So conclusion, twin pregnancy with pre-existing complete heart block can have favorable maternal and neonatal outcomes with early diagnosis, multidisciplinary care, and judicious use of temporary pacing during labor. Careful maternal fetal monitoring and guideline-based pacing decisions are crucial. Sir, Naveen sir, please add some lines on temporary and permanent pacemaker.
That's it, madam.
Okay, coming to okay.
Something I just want to add. So when you are using cautery, when permanent pacemaker is, just change it to AOO mode. It's not DDD mode, all not recommended. Only that thing you have to, when it is permanent pacemaker.
Okay, so this is a temporary pacemaker, so we were on demand mode. Okay, next case is, this is a case of antenatally diagnosed premature closure of ductus arteriosus, and we could manage with the help of pediatric cardiologist and neonatal team in our hospital. So what is ductus arteriosus? It connects pulmonary artery to aorta. This ductus arteriosus will be patent in fetal life because of low oxygen tension and prostaglandin E2 levels in utero. And because lungs are fluid filled, they have high resistance in utero. So the blood from the pulmonary artery bypasses through the ductus arteriosus into aorta. After delivery, because the lungs aerate, resistance decreases and the ductus arteriosus gets closed. So premature means premature closure of ductus arteriosus is a rare and severe condition caused by usage of NSAIDs or polyphenol rich foods during pregnancy. So this is a case of 25 years old Raimi. She had initial antenatal checkups outside and she was referred to me at 38 weeks of gestation, telling that the baby has some cardiac anomaly. NT, TIFA, growth scans done at 28, 32 weeks were normal. And they diagnosed abnormality in the fetus at 38 weeks and they sent to me. So the images of the baby when I saw for the first visit. So this is the 4-chamber view. We can see the discrepancy in the size of the chambers. Right side is more enlarged compared to left side, and I couldn't see any flow through the right chambers. And coming to 3-vessel view, pulmonary artery appears to me dilated with no flow through the pulmonary artery. Then Jyoti Prakash sir was my survivor. So I went to Jyoti Prakash sir, sir, this is my findings. Sir confirmed that it is a premature closure of ductus arteriosus by repeating the fetal echo. So we counseled the couple and we posted for elective LSCS and we delivered 3 kgs female child. Baby had thick MSL and respiratory distress and baby was shifted to NICU. Now NICU care will be dealt both by pediatric cardiologist and Tanveer ma'am.
You start.
Good afternoon, everyone. I'm Dr. Tanveer. When the baby was delivered with a birth weight of 3.0 kgs, the baby had a good cry at birth. Later, we saw that the baby is having persistent respiratory distress. As we know that the ductus arteriosus was closed prematurely, we were in a plan to intubate the baby. Anyway, the baby has persistent distress first with the pediatric cardiologist on the side. We did the echo. Immediately after birth, the flow through the ductus arteriosus was nil. No ductus arteriosus was seen. So we intubated the baby in view of persistent distress. Then we started the baby on IV sildenafil, which is a pulmonary vasodilator, as the right ventricular systolic pressures were much high and the right ventricle was pretty dilated. So we have started the baby on sildenafil, and the baby was intubated for 2 days. With the help of pediatric cardiologist opinion, we tried to wean off the baby from the ventilator to CPAP, then HFNC. On day 5, the baby was out of ventilator and the baby was able to maintain its saturations on room air, and we discharged the baby on day 10. So this is the X-ray of the baby on day 1 of life. The baby had, sir, will you throw the light on echo findings?
So yeah, this is a very interesting case. So this one actually we kept here because majority of the times the foramen valve and ductal arch are actually underdiagnosed in utero. So here why we want kept is because the intactness alone of foramen valve and ductal arch is not sufficient. So you have to mention whether they are adequate or not. So go back to previous slide. So this fortunately the mother when referred, it's a 38 weeks, though that time actually, go back to prenatal. Fetal.
Prenatal episode.
Yes. Yeah. So here you can see that there is a significant ventricular disproportion, and when I see the third vessel, 3-vessel view, the PA is grossly dilated and aorta is suboptimal. So means it's not there. And when we look for the ductal arch view, the ductal arch was not at all seen. Almost it is regressed completely. It is not at all visualized there. So then immediately I got that doubt. Means, and after seeing that there is a significant RV dysfunction, and there is a, actually here it's not seen clearly, but in my images it was there. There is a significant pericardial effusion, almost like impending signs of hydrops. So go back to the postnatal echo. So the chest X-ray, anyway, you saw that there is a significant cardiomegaly. Okay, run the image. So you can see that there's the left side one is that is the left atrium and the left ventricle are okay, functional well. If you see the right one, there is a significant right ventricular hypertrophy, and there is increased echogenicity of the right ventricular myocardium, and including there is a significant RV dysfunction. And when you see that the cavity, the RV cavity, it is almost compromised, and there is a significant TR. That TR gradient is around 50 mmHg, means which is actually underestimated because of RV dysfunction. Means the PA pressures are much higher than that. And when you see immediate after newborn, the second image, if you see, there is no PDA at all. The PDA at least expected in first 72 hours, we will be seeing at least some amount of PDA. But immediate after birth itself, the PDA is not visualized. So this confirms our diagnosis of premature closure of ductus arteriosus. The fortunate thing here is actually it is drug induced, and actually the patient party didn't reveal to me they have taken NSAIDs just a week before when they came to us. But the advantage is because they are, by the time the RV dysfunction settled, it is 38 weeks. So we electively induced the patient. So we delivered the baby. So luckily there is no endocardial fibroelastosis for the child. So we started an IV sildenafil and managed. We kept everything back up, with, including that. You can see. Yeah, show me this video. Previous one. You can see that the PFO is bidirectional here, showing that there is a significant severe PAH. So yeah, you can see that the PFO is bidirectional there. Okay. So luckily, the child went home without any sequelae and morbidity. So post procedure means sorry. After discharge, the baby was continued for sildenafil for another 6 weeks, and right now child is doing well. Now I think 4 months has follow. Can you
And,
show the other images, ma'am?
the baby was discharged on day 10 on oral sildenafil, and the baby was having regular follow-up with us. Now the baby is thriving well at 4 months of age. This is our recent picture with normal development appropriate to the age. I thank our team for helping us, Anuraha madam also for, and cardiologist team.
So here itself it shows that the always
Team
group
effort.
is
Team
a
effort
must,
is,
because it was diagnosed at right time, referred at right time, and managed at right place. Okay.
So most premature closure of ductus arteriosus are diagnosed postnatally, but ours is a case which we could diagnose antenatally and could give appropriate treatment with multidisciplinary support. Okay, so what is NSAIDs are better avoided in pregnancy if used for the maternal benefit for anything. We should monitor the fetus for congenital anomalies in the first 20 weeks and later for oligohydramnias and premature closure of ductus arteriosus by antenatal ultrasound. So early diagnosis is critical for management, and close monitoring and intervention improves outcome. Last case, mice, is dengue in pregnancy. Recently, in this month only, we got this case. She's a 19-year-old primigravida with 35 weeks of gestation, referred to our hospital in view of dengue with severe thrombocytopenia. At the time of referral, her platelet count was 20,000. So she had fever 4 days back, and an evaluation found to have dengue fever and S1 antigen positive. She was admitted at local hospital and managed conservatively as platelet count was 83,000. Later, her platelet count dropped to 20,000, so they transfused one SGP and referred to Ramesh Hospital for further management. So on examination, she was 34 to 35 weeks uterus, and NST was reactive. On vaginal examination, clear leak was present with 2 to 3 centimeters dilatation, presenting part vertex at -3. So what is dengue fever and what is dengue hemorrhagic fever? I think everyone know. So I'm going to the recognition criteria. So if the mother has fever, body aches, nausea, vomiting, rash, leukopenia, and any warning signs, this comes under recognition. And like warning signs, if she has persistent vomitings greater than 3 in 24 hours or diarrhea greater than 3 in 24 hours, third space fluid collection, lethargy, restlessness, abdominal pain, tenderness, spontaneous bleeding, raised hematocrit, rapid drop in platelets, then these come under warning signs. So this checklist should be there in every hospital. This is from Fernandez only. I also continue the same. Okay, so this checklist will be there. So you should have a recognition criteria, warning signs, what are the symptoms in severe dengue, and then you come to the diagnosis like dengue fever without warning signs, with warning signs, and severe dengue. And we should daily check the status of the woman and see how is her temperature, BP, mean arterial pressure, pulse rate, respiratory rate, hemoglobin, hematocrit, WBC count, platelets, all these to be tested daily. So because this is in the third trimester and about to deliver, we need to suspect the vertical transmission to the fetus also, and we should alert the neonatology team. And pregnant mothers come under special group and need admission even in the absence of warning signs. So coming to my case, she is dengue fever, NS1 antigen positive, and she has warning symptoms, that is third space fluid collection, raised hematocrit, rapid drop in platelets. So she has warning signs. And now coming to, we have another phase like fever, critical, recovery phase. So 1 to 4 days is the acute phase, 5 to 7 days will be the critical phase, and above 8 days will be the recovery phase. So this lady presented on 6th day. So she is a lady came with dengue in critical phase with warning signs. So what should we anticipate? She is already in labor. So chances of postpartum hemorrhage will be more if she deliver even vaginally. So she progressed and we were making ready for the blood and blood products as the platelet count was only 20,000. And she progressed spontaneously and had a normal vaginal delivery with SDPs, single donor platelets on flow. She had severe postpartum hemorrhage. We gave all the oxytocics, carbetocin, misoprostol, methergine, tranexamic acid. Even then she didn't respond, and so we need to go to the next procedure, uterine tamponade. And we have done uterine tamponade with Bakri balloon and vaginal packing. And total blood loss was 3000 ml, and we transfused 4 SDPs, 1 RDP, 4 FFPs, and 2 packed RBC in the 6 hours. So coming to PPH, so we emptied bladder, we gave all oxytocics, and the final is uterine tamponade, compression sutures, arterial ligation, embolization, and hysterectomy. Luckily, my lady responded with uterine tamponade, so and blood products. So as we were transfusing so many blood products, everything, her saturations was dropped, and so they intubated, and the delivery I have done in the OT, so operation theater. So I should thank all my anesthetist and critical care team who helped me in managing this case. And they intubated the mother, and she developed basilar cryptations, and we shifted to ICU for close monitoring. And to decrease the pulmonary edema, again we started her on dietary infusion, and we monitored her. Luckily, she didn't develop PPH. Further, no PPH, and she's fine. And we removed Bakri balloon and pack after 24 hours. And total 3 packed RBCs were transfused post-delivery. And here hemoglobin for 7.5 grams, for which we gave FCM injections. See the hematocrit and platelet count at the time of admission. Our hematocrit was 39.2 and platelets 22,000. Slowly, by the time we discharged, our platelet count was 1.9 with 21 hematocrit. Now, our neonatologist, Dr. Mahesh, will tell about the baby, how he could manage the neonate, because the lady was in active dengue infection.